My name is Eduardo Rodriguez Zoppi. I'm a vascular and endovascular surgeon at the Memorial Healthcare System, and you are watching the Cyber Health Podcast.
Welcome to the Cyber Health Podcast. I'm Stephen Perano, your host, and alongside of me is my co-host.
Hi, everyone. My name's Tiffany Perano. I'm excited to be part of the show. Today, we have our special guest, Dr. Eduardo Rodriguez Zoppi. He is the Chief Vascular and Endovascular Surgery at Memorial Healthcare System.
Thank you so much for having me. It's
Welcome,
a pleasure
Doc.
to be here.
And we do appreciate you coming to the studio. We're going to bounce around this interview, so let's kind of go back to, I recall watching an interview you did a few years ago that you had mentioned something happened with a friend of yours that kind of inspired you to get into healthcare.
That's actually how I decided to go into medicine. So I was actually in 5th grade. So when people ask me how I decided to be a doctor, that's a classic question. And so we were in the middle of recess, 5th grade, and we were like goofing around playing a very dangerous game where you push on the chest of your friend. And my good friend from that went down on the floor and started having a seizure.
Oh.
And of course, everyone paralyzed. And I had the instinct to just jump and kind of grab him, and I held his head because he was kind of hitting the ground, and I didn't know what to do, but I kind of reacted. I was the only one who tried something. Eventually it resolved, and then so we went to the nurse, the school nurse, and then I remember clearly she told me well, you actually did a great job. That was what we were supposed to do, and that was it. From that point on, I was officially the doctor of the class. And
In 5th grade.
And then I started doing first aid courses during summer break, and that was kind of always had that mentality, and people would come to me for advice, and during high school years and stuff, made up stuff and some of the stuff that I knew from first aid, but I always had an answer. And
So it's funny how as a young kid, you said you're in 5th grade,
yeah,
right? And so your instincts just kicked in when you saw your friend falling. Going back now, we're moving around now in your current state of, clearly you're a board certified. Is that American boards?
yeah, the
Okay.
board.
That's a
Amer-
joke, by the way.
Did complete some interesting part of my training in Venezuela that I think made me who I am. So, there are two experiences that I can share with you. And so when you're in med school in Venezuela, they're still during your medical school time, you're supposed to do a rural rotation. And people go to different places, and I elected with my good friends to go to a very, very remote area in the east coast of Venezuela, in El Delta Amacuro, which is, you drive 8 hours from the capital, and then from there we had to take a 3-hour boat in the river of the Delta to an indigenous community. We had no water, no running water, no electricity, only an electric plant for a few hours a day, and we were there for 3 months.
Wow.
So I think that I think if I had a message for the people that are listening is, it's everything is about perspective. So here, when I'm here, and I have in my room now, I have access to pretty much every single toy that I can ask for to do surgery.
Right.
And I remember my days when I was in the middle of the jungle, where I literally had nothing. I remember the governor, when we were there, came in a boat and had a big shipment of supplies that was supposed to last for 3 months, and it was literally 3 boxes.
Wow.
That's and it was that was a major event, pictures and everything.
Right.
But it gives you perspective of what other parts of the world as people go through, and we're blessed in the United States that we have access to every single technology and advancement, and but I always keep that in mind, where I came from, and what things are in other places.
And what drove you to want to get involved with that?
Do you mean that to that rotation, or well, I wanted to kind of experience that, the real world, because some people like would stay kind of close to home, and we were like a group of friends, and we were like, well, if we're gonna experience it, we're gonna go remote.
Right, 'cause that's
And
on the
then-
extreme
Yeah,
opposite.
yeah. So it's a good experience, and then. For my rural rotation, like once you finish medical school, since I was still thinking that I was going to come back to Venezuela, then you're required to work for a year as a rural physician, where you do everything, and then you are prepared during med school to be a physician like right away. So 2 weeks after I finished med school, I was practicing in this rural area. It was not that remote. It was like an hour from my house, and but you're there. I was my best friend from med school and I on call. No one else. It was just the two of us, and then you can get anything from a gunshot wound to women in labor to pediatrics, everything.
Wow.
So you become a real doctor very quick. So I did that because it's a requirement. So I was thinking, well, if I do this and then I go do my residency in the United States, when I come back, then I'm done with that requirement and I can practice. But I ended up doing that, and then I came here and I never went back.
Do they have anything like that in the States? A rural residency?
They have rural doctors. I mean, but usually those are primary doctors, and
Right.
and then some of those positions are underfilled, and it's part of kind of our health care crisis.
Right.
In some of the rural areas, you don't have, and those positions are filled actually by some foreign medical graduates that come to the United States, and those positions are not as competitive as
Right.
you might imagine.
Right.
So then some of those positions are filled by people that come from other countries, and then they go through the boards and everything, and then just go to rural areas.
Got it.
So from there, then you came over to the States to do your residency,
Correct.
and where did you do that?
So I applied all over, and I was offered a pre-match position at the University of Pennsylvania, and I took it. When you come as a foreign medical graduate, you usually get, especially for surgery, since it's very competitive, you don't get into the residency in what they call a categorical position. You get as a preliminary position, which means that you're not guaranteed that you're going to finish the whole thing. So I worked my behind to really kind of merge, and I think what really made a difference was that I really was able to understand the culture and adapt to the culture and the work ethic, and it was a reality check for a guy like me coming from Venezuela. My first co-resident at Penn, my first ever rotation. You have another intern with you, and my co-intern was a guy who was going into orthopedics, and he was the number one from his medical school from Harvard.
Oh, wow.
So you can imagine how
Right.
smart the guy was.
Right.
And I was you're humbled. Like when you're like when you have someone like that.
Right.
But I used the opportunity. I learned I was like a sponge, and I just learned a lot of the things from him. But on the other hand, and this was a nice compliment that we had, was it from like the practical standpoint, from the like hands-on experience. I had more experience because I had been a doctor on my own for a year already, and I had done a lot of stuff in Venezuela before. So for doing procedures, I was a lot more advanced and aggressive to a certain degree compared to them. So I would teach him some of those kind of practical life skills, and then
Right.
he would teach me some of the more kind of methods, organization, how to do the notes and stuff like
Right.
that.
And did
My English was not as
that's
good.
what I was
Not
going to
that-
ask.
Not that my English is great now, but it's
I think it's great.
yeah,
That's
it's
like, was there a-
but it's no, but it was like one of my first rotations was on the transplant service,
Oh, wow.
and the fellow that was training under the translator was a gentleman from Egypt with a very thick accent. And my co-resident was a good friend who was from Bangladesh, but had been raised in Ireland with a very thick Irish accent.
Okay.
I spent the whole month say, I'm sorry. Like I didn't understand.
Between the three of you?
The guy just, the fellow just wanted to like strangle me every time I said, I'm sorry. It's like, what part did you don't understand? It's like, dude, I don't understand your accent. I don't know. I'm sorry. I don't.
Yeah.
So, but yeah, I mean, that was part of the learning process.
Now, is there anything out of that rotation or through your time and your training, primarily for vascular surgery, that stuck out to you and said, I'm home. This is where I want to be. Like I made the right choice.
Yeah, no, I'm definitely, seeing how like having access to the latest equipment, the latest, procedures, the latest literature. Like you literally are doing stuff. I was at Penn doing surgery with the guys who like write the books. So having the access to that is like a different level of training. So, and then from there, I completed 7 years at Penn because I did 2 years of research. So it's 5 years of general surgery, then 2 years of research in the middle. And then from there, I knew I wanted to practice in Florida just because it's closer to home. So I chose USF in Tampa for my fellowship, and I did 2 years of fellowship there. It was a great experience. And then I knew, so I started looking for jobs, and I saw the opportunity at Memorial, and this I think, if there's anything again that I can tell to your listeners about when there are points in your career where when you make decisions, you kind of have to think about the future, about where you're going to be. And I saw the opportunity at Memorial because the three surgeons that were there were seniors. So Dr. Palamara, Dr. O'Donnell, Dr. Hertz were significantly more senior than me. And when I saw that, I was like, this is a perfect opportunity for me, not only because it's going to be great to have senior partners with experience to help me out, but also long term, I saw myself kind of taking over and being in charge eventually once they were retired. So so I did have that kind of in mind. We'll talk a little bit more about how it happened later, but and it happened a lot faster than what I anticipated. But that was kind of part of the whole decision-making process. And it's interesting because when I applied to Memorial at the time, I still have a working visa. I was not a U.S. resident. And then the process to become a U.S. resident when you're a physician, is very, very difficult. And I still had a what they call an O1 visa, and when I was applying to Memorial, I was not even going past the first checklist.
Wow.
They were not calling me, so I went to a conference for the Florida Vascular Society, and my former boss introduced me to Dr. Sean O'Donnell.
Wow.
And that's it. We clicked, and then he gave me the job.
Wow.
But there's a little bit of luck. There's a little bit of being in the right place at the right time. Medicine has a lot of that. And I've been blessed to have, I think, both at Penn. I had that click with Dr. Noel Williams, and then at Memorial with Dr. O'Donnell.
Now, real quick, I want to touch on something you mentioned about the conference you went to. Some of our viewers are students, professionals. Some people are looking to change careers. But I just want to touch on real quick, because in myself in technology, I go to a lot of conferences, and that's where I meet a lot of people. Although I talk to other people that they're not interested, they feel like it's a waste of time. I'm just going to go there. And yeah, I might meet some people, but there's really just people from other organizations and companies trying to sell me products. I don't have time for that. But I see on the other side, I see it's a big value to go to these conferences, and in particularly in your situation, that really set you for your future by going to that conference.
Oh, definitely.
You know.
In medicine, it's a it's a place where we go not only to get some new knowledge and the latest literature and updates and papers and research publications, but also networking.
Right.
Networking is key, and then you get to meet people that you would have never guessed, and then eventually you see them again in the next conference, and then you start developing more and more relationships, and then you can ask, like, so what are you doing for this? And then when I usually do, so I just came back from a conference last weekend. I was up in Denver, and I met with some colleagues, some friends from Sarasota. And I asked them, well, so I'm having this challenge. Well, how are you guys doing with this? And I got some very great ideas from them. And then that's how you start getting new ideas on to solve some of the challenges that you might have locally that maybe they already thought about something that it didn't even cross your mind.
Right.
Yeah.
Are there any breakthroughs currently in vascular surgery that are interesting that you'd like to share, maybe?
Well, when I decided to go into vascular surgery, the reason why I did was the first time that I saw what we call a vascular anastomosis, when you put together two blood vessels together. That's called an anastomosis, and it was actually during a kidney transplant. And then the fact that you connect it, and then you open the clamp, and the blood goes into the organ, and you see the organ that is pale, and then it becomes full of life. That was it. That's how I decided to be a vascular surgeon. But now, you see, our division is called Vascular and Endovascular Surgery, and the reason for that is because the now advancements, which applies to medicine in general, a lot of things are now done minimally invasive. So, and the endovascular branch of vascular surgery is all the procedures that we do through catheters and wires that go inside of the blood vessels, and then we do treatments that way. So the whole range of things that we now do, from repairs of aneurysms to carotids with the stents that are these little covered mesh, or devices that open up some of the blockages or cover for like an aneurysm. Every single day you get new devices coming out.
For a patient standpoint, for example, because we also have patients that perhaps unfortunately may have to undergo an aneurysm procedure. If you want to touch on real quick about the difference between an open aortic aneurysm procedure compared to an endovascular aneurysm.
So the main difference is how big the clot is. And what you're using. With the open procedure, which is kind of the classic repair, you're making a big incision, you're going in and you're cutting open the aneurysm. The aneurysm is just a big bulge. The vessel, instead of being a tube, is become like a balloon. And the problem with that is it can burst. And if it bursts, people bleed and they could die. And it's a silent problem that people don't find out unless they get a scan or they get a screening ultrasound.
What's the typical symptoms that somebody might, if they didn't do that?
That's the problem. They don't get any symptoms. If it bursts, you get pain, and 50% of the time people don't even make it to the hospital. So anyone out there who's smoking, quit smoking, and control your blood pressure. And if you're a smoker older than 65 years old, then you should get a screening ultrasound to look for aneurysms. So in the open repair, you open the aneurysm up, and then you replace that with a graft, which is a synthetic piece of tube that connects the arteries and then bypasses the area that is aneurysmal. With the stent graft, what you do is you go from the inside of the blood vessel and you put the stent that is covered, and now the blood flow is going through the stent and is not going outside of that. So now the aneurysm is completely excluded from the blood flow, and then eventually it shrinks. So the recovery is a lot faster. There's some patients that are not candidates for an endovascular, for a stent graft, and then we still have to do them open. That is one of the challenges now, which is Some of the newer generations are trained in the era of endovascular repair, and they're not used. That the open operations are less and less frequent. So, I was blessed that I trained in an institution where we did both. So I feel fairly comfortable doing both, and I can offer the patients both. But it is a concern that's in the future, and this happened in general surgery, gallbladder surgery. It's a classic example. I used to do open gallbladder operations. Now everyone is doing it laparoscopically.
Right.
And when some of our general surgeons have to, in general, have to do an open gallbladder, they might struggle. They might need to call some of their senior partners because they're not as familiar with the open operation. So that is, everything is a trade
Right.
Sure.
in medicine. And there's no perfect one solution. So the advantage is, our group of surgeons at Memorial, we're able to offer both, and then we do whatever is right for the patient.
Right, of course. And you also mentioned there about carotid stenting and the stroke rate of patients. What are you seeing more of in your experience in the last, let's say, 5 years?
That is, speaking of breakthroughs, it's and the conference I just came from was about that. Traditionally, for carotid disease, there's the traditional carotid endarterectomy, which is the open surgery, open version of, and the carotid artery is the main artery that gives blood supply to the brain. If you have a narrowing that is significant, that can cause a little plaque to break off and go to the brain and cause a stroke. So sometimes we have to do surgery to prevent a stroke. And that carotid endarterectomy is the classic way of doing that repair. You open the artery, take the plaque out, clean it up, and put a patch on it. The alternative to that was a stent, which traditionally was done from the groin, from the femoral artery in the groin. You go all the way in a catheter, go all the way to the arch, and then go to the neck. Now we have a newer technology called transcarotid artery revascularization, TCAR. And the difference is that now instead of coming from the groin, we go in the neck, make a small incision on the base of the neck, and we put a catheter, and then you connect that to a catheter in the groin going into the vein. And the system has a system of tubing and a filter. And then you activate that, and now the blood is reversed away from the brain, going from the brain into the vein, going through the filter. And then we put the stent through that approach. So the data on that procedure is significantly better compared to the transfemoral in terms of stroke rates. And the whole principle is that flow reversal system. So, we're doing that procedure, and again, the anatomy and each individual patient determines what's best for them. Right. We still do with some of our neurointerventional radiology colleagues. There are situations in which we have to do the transfemoral approach. So I think the most important thing is just to do the right thing for every patient.
Sure. You touched on it earlier, mentioning about, for patients to, not smoke and control their blood pressure. But on the flip side of that, what are some misconceptions that you hear from patients that you see about their overall health and when it pertains to vascular surgery?
I think the most common one that comes to mind is veins. Because, we deal with, usually for arterial problems, blockages, those are almost strictly related to smoking. But we also see young female patients with varicose veins, and then this misconception of, if you have varicose veins, does that mean that you have bad circulation? Or am I going to have a stroke because I have varicose veins? So, that understanding, and we even get that from some people involved in the healthcare, the understanding of the difference between arteries and veins. The arteries take the blood from the heart to the end organs, to your feet, to the brain, and the veins take the blood back from your legs, from your arms, back from your organs, back to the heart. And when you have venous insufficiency, which is issues with blood going back from the veins to your heart. There are some these valves inside of the veins that are supposed to keep the blood from going down, and when they start failing, they get venous insufficiency, and that translates into varicose veins. And so usually people are extremely worried about blood clots and things going to your brain or having a heart attack related to varicose veins, and these are two completely different problems that are managed completely different.
Right.
One thing I can remember when I was doing my rotations back in school was seemed to be a lot of patients, at least maybe when I was there, I don't know, thoracic outlet syndrome. I found that was pretty interesting because it can happen in young people, and not many people know what it is.
It is a condition that we treat. Actually, one of the leaders that trained me at USF was a national renowned surgeon, and we wrote papers and book chapters about thoracic outlet. And it's a condition that is very difficult to diagnose because not a lot of people know about it, meaning physicians out there, and the patients can present, and people just, if you don't think about it, you're not going to be able to make the diagnosis. And it's compression of the vessels or the nerves that come out of the chest and go to the arm through the thoracic outlet. So the thoracic outlet is this channel where the clavicle and the first rib meet. There's this triangle, and through that space, the vessels and the nerve go through the arm. And you can have arterial thoracic outlet, venous thoracic outlet, or neurogenic thoracic outlet, depending on which structure is getting compressed. The one that we see that we treat the most is the venous, because usually it presents abruptly with a blood clot in the arm, and it's related to people that have either professions or play sports that imply repetitive movement of the arm over the head, like professional pitchers. I had
tennis.
I had a patient once that was a flamenco dancer.
Oh, wow.
Then any condition where you have repetitive swimmers, that movement overhead causes inflammation in this area. There are some patients that just don't have anything and have a genetic component, and they can have it without having any of those professions. But yeah, it's one of those conditions that we treat that sometimes is misdiagnosed.
Yeah. Talking about medical school and your residency, do you have any advice for residents or med students that are interested in coming into vascular surgery?
You really have to love it. This is the one. This is a specialty that requires a lot of sacrifice. It's this applies to a lot of medical of specialties in the medical field, but for vascular surgery, there's a lot of sacrifice. If not, ask my wife about it. She knows a lot about sacrifice, and I thank her for everything that she sacrificed because of my profession. So it's you really have to love it, because there's emergencies. These patients are very sick. You have to be very detail oriented, and from a technical standpoint, the technical aspect of the surgery also, and this is one of the things that kind of made me fall in love with the specialty, is the technical aspect of the surgery is very detailed.
Are there, speaking about technical, I know you're working on very small vessels sometimes. Is there a robotic aspect for vascular surgery now, or is it all still kind of?
Not much. There is some robotic for some of the endovascular. There's some robots that can help you manage some of the wires, but for the open, there's really nothing that has replaced good hands.
Right.
Right. And piggybacking on the residents, you work with a lot of residents lately, and how does that change, or how does that add to your overall day-to-day?
Time. You have to spend time teaching. Teaching takes time, and then it's a difficult balance to be able to get to see all the patients that are waiting for you, that are really want you to take care of them. The reality is that when we have residents, if I don't have a resident, I can probably do 6 cases in one day. If I have a resident, I might have to do 3. So those 3 patients will have to wait. But we try to keep a balance, and then we have in our division, we share the training of the residents, and we try to keep that balance to keep moving with the service aspect of the division and the educational aspect of the residents. Vascular surgery is a critical component of the training for general surgery, so we're a very important component of their program. But it's great. I mean, I love teaching. I wish I had more time to do it. I grew up with the influence. My dad was a professor in a university. He's a chemist, and he taught in a university, the engineering campus for 35, 40 years.
Wow.
So he's a natural teacher. So I kind of got some of that from him.
Nice. We're going to move off on the residents, but the last question for that, because I've had a couple of residents ask me to ask you this. If residents are watching this, they're going to have a rotation with you. What are some tips they can bring to the first day that can help them shine, help them be more prepared in your eyes?
Triple shot non-fat latte cappuccino. That's a good start. So read, prepare before you do a case. You cannot show up and not know enough about the patient. Before going into residency, for like anyone who's in med school, the key, I think, for most of the big academic places, and if you want to go into a place, a competitive residency, is research. So get involved during your summer breaks, or even kind of part-time. Find that a place in your local community where someone is doing research. And it doesn't necessarily have to do it specifically about the field that you want to go into. If you're going vascular, it doesn't have to be vascular. If it's vascular, it's ideal if you know that you want to do vascular, but any kind of research, because that implies that you have that curiosity about science and all the work that you have to put into research translates into better preparation and better physicians after training.
And speaking about work-life balance, you mentioned you owe a lot of praise to your wife for being understanding. So how do you maintain that work-life balance now in your career?
It's the hardest. That one is the hardest. I might start crying here. This because you're torn. You're torn like every single day at 5 p.m. I'm torn between I have to do this extra, but I just want to go back home and see my wife and my son and be able to play with him. But then, so, having that balance of doing the right thing for the patients and not leaving the patient waiting or delaying care, but then also being present for your family. It's a challenge. And I try to do it in a way that it's the way I schedule things then allows me to not overstep one thing over the other. And then just when I'm with my son, try to get the most out of that time. And then really lately trying to do trips, because that's the only time I'm really, really disconnected.
Sure.
In this position now, the chief of the division, there are other responsibilities in addition to the clinical responsibilities, and my phone is never off. I always tell people, I sometimes make this comment to my wife is I wonder what it feels like to call out at work, to call and be like, I'm not coming today.
Right.
It's like something that people just you're not feeling well. It's normal for a lot of people, but I just can't. And that and the fact that my phone can never be off. So like right now talking to you, my phone is vibrating in here, and I'm like itching to know, like it could be something from from the
and
hospital.
then
So
You're not on
look.
call or
so-
anything, are
no,
you?
no, I'm not. I'm not. I'm not. So, but it's my a night,
Yeah.
every single one of those telemarketer calls that you send to voicemail, I have to answer it.
Oh my God.
Because I don't know if
You
it's a
never know.
number. If it's a I could be someone from the hospital. It
Right.
could be something. So I have to answer every single time.
Mhm.
The things that we get for granted,
Sure.
and I'm not trying to like be a victim here. It's
Yeah.
but it's something that people out there might not know about the life of a vascular surgeon.
Yeah.
I'm sure that if I had the time and I made like an Instagram account or TikTok, whatever, one of those things, people following me around and like seeing like the real life of a vascular surgeon,
Yeah.
that would be interesting for
Yeah.
people to like really see what it is like, and
Yeah.
it's rough.
Right.
But that's going back to what we talked earlier. You got to love it. If you don't
Sure.
love it, I'm never miserable. I mean, you guys have seen me in the hospital. I'm never in a bad mood. I'm never in the hospital like being like, oh my God, I just want to get out of here. I mean, when I'm there,
Right.
I'm happy because I love it, and that's why if you go into this, especially for vascular surgery, you gotta love it, or you will be miserable.
Yeah.
And going back to what you said before, how you were in Tampa and you saw an opportunity here in Hollywood, you saw some senior partners that you would be, working with, and one of those partners, Dr. Jeffrey Hertz, he was a partner of yours, an amazing physician, an amazing person. He passed away last year, and I don't know about for you, but that's the question I'm getting at. For me, he was very young, and it was a sudden thing that happened. But when it did happen, it made me reflect on my life and where I'm at in my stage of my career, in my personal life, and really it made me make my time as far as work-life balance more of a priority. And I don't know if you started maybe traveling more after that. What was your experience like losing a partner on a professional level, but then also on a personal level, because he was a husband as well, and he also had obligations and a family. Did you reflect at all in your life? Did that change anything for you?
One of the hardest moments of our lives, and it definitely kind of it makes you wonder, like, is it worth it?
Right.
Like, am I doing the right thing? Like, it makes you reflect on a lot of things. The work kind of sometimes pushes you into like not being able to think that, because it's just overwhelming. But definitely, Jeff was an amazing clinician, an amazing friend, a great husband, a great, one of the most efficient physicians that I've ever met. The guy had everything always done on time, and it was because he was really good at managing the time and the balance, and he was really good at planning. And then sometimes I think that's the one thing that I learned from him, and it was that if you plan things the right way, you're not going to be running around like a chicken without your head. You never saw Jeff kind of scrambling, going like, and I was like, how do you do this? Like, how
Very calm and collected.
How can you like finish every single note on time and be like nothing had pending? Like every time I had like my ultrasound reads and I had completed them, I was like, it was like a party in the office, and he was like, and I was asking for like a gold star from Olga, our ultrasound tech, and he would like be in the office. His office was next to mine, and he would be like, "What are you happy about? That's your job. And, what's so exciting about it? You were supposed to do that all along." He's like, "Yeah, you're like Superman. I can't know that you." So he's definitely. So, and that and I think speaking of like being in the right place, the right time, I am the product of a combination of three amazing surgeons. Of course, I got all the training, Penn, USF, that made me a very strong physician. But then when I got to Memorial, it was like a super fellowship. I had the combination of three amazing, very different surgeons. You know, the calm, collected, planned, efficient Jeffrey Hertz.
Mm-hmm.
You have the passionate, sometimes controversial Arthur Palmara.
Mm-hmm.
But, no one can be as passionate about his patients as he is. You're never going to have anyone that can advocate for a patient like Arthur Palmara. And then the master clinician, always politically correct, always, practicing medicine, evidence-based medicine, Dr. Sean O'Donnell. Mm-hmm. So that combination, I'm not even near what my hope is, but my goal is to, like, 20, 30 years from now, be the full complement of those three physicians. If I can even get a little close to any of them, then I'd be very happy.
Well, I'm sure they appreciate those kind words you say, the sentiment about each one of them. I've had the privilege of working with all of them, and yes, I can say that it is a privilege. It is a privilege to work alongside of you and your partners for these many years. How long have you been now at Memorial?
9 years.
9 years.
Yeah.
So then I came a year after, because I just celebrated 8 years. That's something. Well, we're going to lighten up the episode a little bit, and this part I'm going to kind of let Tiffany take control of. She had some great ideas, so I'll let you go ahead and introduce the games and the wheel.
All right. Now the fun part. Okay. So we have here, this is our new addition to the podcast. We're going to bring this in sometimes. You can pan in right there. Okay. So it's called the Wheel of Destiny. You might change that name, but it's a little fun game. Just going to spin the wheel, see what happens. We're going to spin it about 3 times, maybe more. There are several categories. I'm not going to explain each one, but when we get to it, I'll explain the game. But, go right ahead. Spin away, Dr. Zoppi.
Give it a good spin. Good spin.
Oh, the best one. Okay. He landed on Bean Boozled. So.
Okay. So the Bean Boozled. Slide this over. Ooh. Yeah. Bring this over here.
All right. So
Go
if you
ahead.
guys never heard of this game, it's called Bean Boozled. Let me show you that box there. Which camera?
Yep.
Okay, there you go.
Okay. Yeah.
All right. So it's a fun little game. It's kind of self-explanatory. We're gonna spin this little wheel. Oh gosh. It has different colored beans, and it could be a good bean or a bad bean.
Oh boy.
So luck of the draw here. And when you spin, we'll read out the color there. The spinner might be a little. Maybe you have to hold it up. Yeah. Nope. Flick.
Is it too tight?
Amazon.
Right.
Oh, I'm just gonna.
There you go.
Yeah, do that. There you go. That'll work.
There you go.
What'd you get?
Hey,
We got what is this? Okay, so it's the spotted red one.
The spotted red one.
Spotted red one. All right. Okay. So it's either good or bad. It's either pomegranate or an old bandage. So that kind of goes with the
So
OR.
let's see. Yes. Go ahead and take a little bite and see what.
This is definitely bad.
We got old bandage.
What does it taste like?
Like an
Can
old
we describe
bandage.
the flavor?
Like, that's a very good description.
Really?
This is like leaking your like the bandage after you came out of research.
Oh no. Okay, you can drink some water there. You gotta get that out of your mouth there. Oh, great job, Bean Boozled. All right,
Oh
what
my
do you got?
God! How do they do
Steven's
this?
turn. Looks like a green spotted one. We have it's either juicy pear or booger.
Oh, get the whole thing in, man. You can't cheat.
Is it good or bad?
What is that?
A booger
Oh,
or
God.
juicy pear?
Yeah.
I guess it's a booger.
Oh, you guys are getting a great answer. All right, let me try a spin. Yeah, this thing is spin. Oh God, I got the black one. I hate licorice. Licorice or burnt rubber. Oh.
Oh boy.
Oh. Those are both bad for me, so either way. I think that's burnt rubber. That can't be licorice. No, that's burnt rubber.
All right, we did one round. Let's give another spin. Then we'll try different games.
Oh, ew.
I got a feeling that they're all Batman. They're like, yeah, boy,
Right.
statistically, we all three of us got the bat one.
Oh, that's pretty bad. How do they get those?
So that's Bean Boozled. That's the game. If you guys are interested, you can find that on Amazon, and you can play with your friends. It's something.
My son's gonna love this.
Yeah.
He's gonna have fun.
All right. So let's give another spin here.
Oh, I still want to knock him.
All right.
There we go. It's a good one. Oh, operation.
Nice.
We're going to perform an operation live on camera here. Wishbone.
Uh-oh.
You got to go for the wishbone.
All
Okay.
right.
So now we're seeing your hands-on surgical skills here.
Okay, this is tough.
No pressure.
One. This is a tough one.
Do you need to move it closer to you? That's fine.
This is.
You want your loops?
Yeah. This is. I don't know. Oh man.
Oh, no pressure.
Dude, I wasn't even close.
You want to move it closer to you?
Yeah, let me.
Need a-
Okay.
Turn the gas on. Patient's moving.
Okay.
Anesthesia.
Yeah, please, Steve. Can you give me a different instrument?
Oh, God.
This thing is not big enough to fit in here.
Oh, my God.
Oh my God! Can you stop the heart?
Oh,
Go and bypass.
I don't think that's where their wishbone's supposed to be, is it? I don't know.
I don't know.
This looks like a wishbone. Doesn't
Yeah,
it?
there you go. No, I'm saying like in the
Oh,
anatomical.
Oh,
yeah,
I
right,
see.
right.
But so this is like close to impossible. Um, just for the record, the tweezers I'm not holding. I promise, if you come to see me, I would not do this to your aorta.
Yeah.
No, I'm taking this.
Oh, he's getting it close.
Yeah.
He's serious now,
right.
folks. Serious. Oh my God. Oh my God.
Hold the patient still. The patient's moving. They're waking up.
There's in no way a gauge of his actual surgical
Yeah.
prowess. Yeah, and
Okay, so the patient has coded 10 times. Stop compressions for now, please.
he's under
He just
anesthesia.
doesn't-
3
All right, let's try a
hours
different
later.
Yeah, wait, I think I got it.
Got it? Oh. I think you lost already. Oh. There we go.
Okay.
Okay.
Woo.
Do one more spin.
That was fun.
One more spin. Let's
Okay.
do
One
one
more
more
spin.
All right.
On the wheel of destiny. Here we go.
Uh-oh. Name the tune.
Name that tune.
Name
You
that-
got something?
Okay.
Okay.
Just for the record, I'm terrible at songs.
You can name the song or the artist, whatever you can think of.
Okay, we're going to give you 2 seconds of the song.
2 seconds.
2 seconds. Man, that's a classic. Is that Cyndi Lauper? No, that's Madonna.
Okay, you can only pick one.
Yeah.
Which one is it?
I think that's Madonna.
Madonna. Is that right?
Sounds right to me.
Okay, it is right. It's Madonna.
Oh, right.
Nice.
Okay.
And the last one we wanted to give you, we wanted you to pick on it.
What's
It
that?
was the,
Oh.
if you can- if you
Guess
can-
who?
Guess who?
Oh, okay.
We got
Yes.
a picture of the, yeah, just put it.
Okay, there
Guess
you go.
who?
Guess
Yay!
who?
All right.
So we're going to give you an image here, and we want you to see if you can recognize who this person is.
We'll put it up.
Oh, that's a good one. You got the soccer. We didn't talk about soccer, so.
Right, which we will.
Yes,
We'll
yes.
put that up on the
Uh,
main screen.
That's a good one. That's a good one.
Who is
So
that?
now, since we're the fun
No.
part of the podcast, let's talk about things that you like to do when you're not performing
Well-
surgery.
Well, I'm going to tell you, I wish I would have brought pictures. So that beard reminds me. So the story that I was telling you when I spent the 3 months in the jungle.
Right.
So the
you switched that.
4 friends before, we shaved like our heads and the beard and everything. So we had the before and after picture. My before and after picture, you can barely tell which one is the before and which one is the after. Instead of the like in terms of the facial hair, like I don't like 3 months not
Right,
without
nothing.
shaving, and I had like a little like shade in here and then a little something under. So that picture that reminds me of that. And then the soccer ball, well, just everyone who knows me knows that when I'm
Yeah,
not
so,
with
yeah,
my
so-
family
uh-huh.
or doing surgery, I am either playing soccer or watching soccer.
And when did that start? When that was when you're young? Or you've
Yeah,
always been
yeah.
a
Like
fan?
every since I remember, I've been playing soccer since I was like maybe 3-5 years old.
Wow.
And then so yeah, I played throughout high school and then university, like kind of the equivalent of Division 1. And then when I came here, I've been playing like throughout residency. I always found where to play. And then most recently, I've been playing almost every year the World Cup of Doctors.
Oh, wow.
So I am part of the Venezuelan national team of doctors,
Wow.
and we go. This tournament is an international tournament that has been going on since like the 80s. Started in Barcelona, Spain, and now goes around the world. So this time was in Australia. I didn't go because I was injured, and plus it was too far in Australia. I couldn't make it. But the year before, it was in Vienna in Austria. I went. Next year is going to be in Ireland.
Wow.
So I'm training for that. And it's great. 24 countries. The real thing. World
That's
Cup
great.
level.
I didn't even know they had that.
And
That's crazy. Can you watch this on TV or something?
yeah, they have like YouTube stuff. Like each year they make it better and better.
I'm going to watch it. I'm going to look for you.
Yeah.
And what is the official name of it?
It's called the what are the we'll have to look it up. I think it's a World Medical Football Championship or something like
Probably
that.
Google it and
Yeah,
find it.
but it's it's in Ireland, Dublin next year.
Nice.
And it's very legit, like 24 countries, 2 divisions. I am officially going to the more experienced division next year.
Nice.
But yeah, it's a lot of fun. Friends, I mean, these are my friends that I used to play soccer with back when I was in med school in Venezuela.
Wow.
That's great.
So it's great. We get to see each other again and share, and then it's a nice, very, very collegial. And only doctors, only physicians. You have to show your certificate to be able to play.
Wow.
And very nice. Very
Safest
nice
place to
experience.
get injured.
Yeah.
Right. And
Oh
do you
yeah.
get your son into it?
You have the the injured guys are on the sideline getting injections and treatment. Some of the guys are orthopedic surgeons.
Oh,
and
wow.
we have our own kit, and then
That's
you can
funny.
do steroid injections, all sorts of crazy stuff.
Wow.
Yeah.
So
Yeah.
even with everything you do on your day to day, you have to have an outlet, right? So this would be your outlet.
Oh yeah. I play twice a week. So Wednesday evening. No matter how many cases I've done, no matter how tired I am, I get out and I go. And again, right now I'm injured, but when I'm in good shape, I go and play. And it doesn't matter how tired I am. It's a one thing. And the good thing is, on Wednesdays it's like 9:15, so my son is already in bed, so I can go and play and enjoy.
Right.
And I don't feel guilty of not spending the time with him.
Right.
Sure.
And then Sundays I play in a league in Davie, and also it's very early, so I usually go like 8 a.m. and then by 10 I'm done, and I can spend the rest of the day with him.
Does he play soccer too?
He's into tennis now.
Oh.
Yeah, I don't want to push him too much into like soccer. He likes it, but he doesn't love it yet.
Yeah.
So, if he ever tells me, "Papa, I don't like soccer," that would be the saddest day of my life. So I don't want to push it. I want
Right.
to let him. If he likes it,
Naturally.
then
Yeah.
Right.
we do have a rule at home. My wife is a Real Madrid fan. I'm a Barcelona fan, but we cannot influence him. We're not. We no shirts, nothing. He has to make his own decision about
That's
which
great.
team he's gonna be.
That's
root
That's
for.
funny. So going back to coming from Venezuela to U.S., did you face any challenges?
A lot. So, I mentioned I was blessed to have at Penn very smart people around me, and I was able to learn a lot very quickly. But from a personal standpoint, when I got to the U.S. to residency, the whole visa thing was a little bit delayed. So when I got here, I was ready to start residency. So I literally got to the U.S. with one suitcase, and I stayed in a hotel for the first 2 weeks of residency. I didn't have a place to stay. I didn't have anything. I didn't have anyone. Of course, I had a lot of support from my parents and my wife. We were not married yet. But she had to stay back in Venezuela, so that was very challenging too. And then, starting, going and doing the whole process of finding a place, buying stuff. So I have a good. Then from that hotel, which was a Travelodge in the middle of Center City, Philadelphia.
Oh, wow.
Then I moved to a little kind of bed and breakfast with this little old lady who was so sorry about like watching me come in every night at 9 p.m. and leaving at 4 in the morning the following day like a zombie. And she was very nice. I wish I could remember her name. And then I finally found an apartment, and then it was completely empty. All I had was a mattress, for which, I got out of the hospital, and I rented a car to go buy the mattress.
Oh my God.
And they got the mattress. Finally got the mattress delivered, and all I had was the mattress.
Oh my God.
For like a week. And so then it was time to get furniture. So of course I went to IKEA. And so IKEA in Philly is kind of in a little bit of a remote area. Keep in mind at that time you didn't have iPhones. So I went. I took the bus and went down there. So during summertime, they have extended hours. So I was literally the last guy, like in IKEA, like finishing everything. And they had like an area where you could schedule the stuff to get delivered, because of course I didn't have a car or how to take anything home. So I finished arranging that. And I come out, IKEA, and it's raining like you never seen. Like it's like the worst storm like you can imagine.
Right.
So I had like an old cell phone with only one number for like a cab company. So I called them. I asked for a cab. I'm waiting. They're not showing up. I call again, and then so the dispatcher goes like, there are no taxis in that area.
Oh my God.
There's no one. So this is 11 p.m. As I tell you, this extended hours on IKEA. So there's absolutely no one there. It's empty parking lot. So I look around and I'm like, so I'm like, I guess I have to take the bus. So, but it's like, I'm talking about like a probably 10-minute walk to the bus station. So I look around, and you know how in IKEA they have the boxes for recycling.
Yeah.
Right.
So I get a huge box over my head, and I start walking in the rain to get to the bus station.
Right.
Of course, when I'm halfway, the box completely fell apart.
Oh my God.
Like from the water, from the rain.
Right.
It just like fell apart. It couldn't hold anymore. So I'm like walking down in the middle of like a storm.
Right.
Yeah.
I finally made it to the bus station, and I'm sure like a lot of people thought I was homeless, and I looked like I was so depressed. I cried. I literally cried that day. I was like, this is, and I'm not trying to be a victim. It's just it's a reality of being an immigrant and coming and having no family, and just some of the things that you might get for granted. Right. Having family support and having a place to stay and having stuff. It's just stuff that you have to go through to make you stronger.
And before we wrap up here, I did speak to a couple people in the operating room that work with you, and from your
Everything
point of
they
view,
said is not true. No.
No, but it really is like a family, and you mainly have probably most of the same people, right, that you work with. So I just want to give you the opportunity, if you wanted to give any particular shout out, or overall, what do you appreciate about the team in the OR? And general?
I mean, it's I think for the people that are not familiar with the way an operating room works, is that we as surgeons always get the credit, but it's impossible to get any of these cases done without the support of the whole team, from anesthesia. Dr. Kimmel is an outstanding anesthesiologist that we use a lot. We have a whole team, and the surgeon for something as complex as vascular surgery, if you don't have a highly skilled scrub tech like Steve, I mean, for those of you that don't know, like, I know that my case is going to be safe when Steve is around. Like, it's like it takes the level of anxiety, because we still get anxious. I've done hundreds and hundreds and hundreds of cases, but you still have a little bit of a level of anxiety. There might be one little technical thing that might be challenging, and when you have someone like Steve, Erlene, Brenda, so from the scrub tech side, and then support, of course, my bosses in the OR. So I have a boss at home, a wife, and a boss in the OR and pain. She's just. It's for me. It's very simple. I just say yes, ma'am, no, ma'am, at home, and then I do the same in the OR with Erlene, Ann, Liz, Sherry. So it's all our assistants. We have a group of assistants that are exceptional. That all they do, it's vascular. Zoltan, Sherry, and now we have a newer addition, Becca, is very eager to work, and of course, Liz Morton, who's been with the system for 30 years, with Dr. Palomar for a long time. I think I always include her in my list of mentors. I've learned a lot from Liz. Every time I'm doing an operation and I hear the hum from Liz, she has this, you're doing this case, and she doesn't, she's extremely respectful, so she's never going to tell you, like, hey, doc, you're doing this wrong. So she has this little, very subtle way of telling you. So she goes, and then like, oh my God, they just added 1 extra hour to my operation because I have to do something different here. So I was like, yes, Liz, I see it. Okay, let's fix this. So I've learned a ton. So it's a teamwork. It's not only the surgeon; it's just a full group, and then it translates outside of the OR to the people that make it happen. Glenna, Rosa, we're the charge nurses that are making sure everything is happening, and then all the way up to the leadership in the OR.
And we won't forget the circulators, the amazing circulators in the room that really kind of push things together. We have what? Yes,
of course. Lexi, Blair, Natalia. There's no particular order. These are all very, very, very good. I mean, they're the ones who, when things are need to move fast, they're trained to get you the stuff that you need, and it's impossible. It's impossible to do this without them. They really. I am a perfectionist. I am very demanding, and sometimes I drive them crazy, and I apologize for that. But it's just, we appreciate what they do for our patients very, very much.
If a patient needed to perhaps see you to get evaluated, what would be the best way they do that?
So our offices are located at, across the Memorial Health System. We have an east location and a west location. I'm located in the east side at the Memorial Regional Hospital. Our office number is 954-265-4664. We have a very strong group of physicians. So in addition to myself and Dr. O'Donnell, who I already mentioned, we have a very talented group. A total of 9 surgeons. On the east side, we have Dr. Habib, Dr. Dower, and then we just added Dr. Villalobos. Outstanding physicians. Any one of us can offer treatment for any vascular condition of the blood vessels, anywhere from the neck to the toes, except the heart. And again, we're always happy to help. So call us if you need anything. But quit smoking if you're smoking.
Thank you so much for watching this episode. We appreciate your guys' support. And if you can, we ask you to share this video with as many people as you can, because the more people that watch us, the more support we can get behind us. If you're interested in being on one of the episodes, you can reach out to me. You can find me on LinkedIn. And again, this was a Cyber Health Podcast. Take care.